I'm going to turn the floor over now to Asmaa Housni, who's a Master of Science student in the School of Human Nutrition, and she will be talking about developing an online education platform to promote self-management in youth living with type 1 diabetes.
Thank you. So hello, everyone. I want to start my presentation by involving you a little bit. I want you to raise your hand for every statement that applies to you, either by actually raising your hand or using your Zoom emojis at the bottom, okay? I want you to raise your hand if you had breakfast this morning. Okay, raise your hand if you ever felt overwhelmed or stressed. Okay, I see a lot of hands. Now, raise your hand if you know how much sugar was in your breakfast this morning. Raise your hand if you think about your blood sugar levels when you feel stressed or anxious, or even on a sick day. Okay, I see less hands now. Well, if you're someone living with type 1 diabetes, you don't have a choice. Your blood sugar levels are always on your mind when you eat, move, exercise, drive, when planning a vacation or going to sleep. Diabetes is always present. I want you to meet Alex. She's 16 years old and she lives with type 1 diabetes. I met her at the hospital. She was hospitalized for diabetic ketoacidosis, which is a common complication for diabetes in youth after she missed insulin treatments. Since she has been diagnosed at 10 years old, she has been learning to live with this condition that has no cure yet. That means constantly thinking about her blood sugar levels. When she wakes up in the morning, she has to check her blood glucose, inject insulin, think about what she'll eat next, because that will change how much insulin she injects and when she injects it. When she has soccer practice, she also has to put that in the equation. The type, the intensity, and the duration of that physical activity all matter, as they will dictate completely different courses of action. Stress and hormonal changes will also impact her blood sugar levels. So the same activities could have different impact each time and would require a different insulin dose. There are so many variables that impact glycemic control, and she has to constantly keep planning and adjusting, thinking about what she'll do next and how it might affect her blood glucose levels. And what does that do? Having to think about everything that you are and are not doing. You have a lot of questions, and understandably so. One question leads to another. And how many people, when they have a question, turn to their professionals? How many people just look it up on their phone, right? Oftentimes we turn to the internet to answer a lot of our questions. It's so easy and within reach, but that might not be your most reliable source of information. Typing your question on a web browser, you'll have thousands of answers, but there is no way to ensure that the information presented is credible. Oftentimes, there is a lack of research and empirical support behind claims made on the internet. And it was actually found that the web usage of informational websites declined over time. And this is because increasing knowledge alone is not sufficient to induce behavior change in diabetes. There needs to be educational quality and a design derived from behavioral or learning theories. There are unverified sources of information and even contradicting information, sometimes not specific to type 1 diabetes. And the answer to a question sometimes depends on a series of conditions and cannot be answered in a generalized way without giving context first. So yes, technology made information readily available, but there are more verifications that need to be done to pinpoint key aspects that need to be included in such technology and ensure that the retrieved information is safe and valid. On the other hand, I can see how waiting for your doctor's appointment to ask questions might be annoying and not efficient, quite frankly. It's not realistic to expect people to wait and reserve all their questions for their healthcare provider when diabetes is a job 7 days a week, 24 hours a day. Another thing to consider is the added caseload during appointments for healthcare providers when diabetes is not well managed on a daily basis, as well as the complexity of diabetes care. And in hospital or community settings, they will generally offer these education programs, but they have limited time and resources. And there are consequences from a lack of knowledge and skills to adequately adopt self-care behaviors. A lack of adherence to self-management behaviors is associated with worsening blood glucose control. And we can see it in youth particularly. About 1 in 2 youth aged 14 to 24 years old has poor adherence to diabetes management guidelines. And a study showed that across all ages, youth had the highest blood glucose levels, with 83% of youth not achieving blood glucose control. They were also the most affected by diabetic ketoacidosis, which is a complication resulting from prolonged high blood sugar. Youth face unique challenges. If we consider Alex, for example, there are several reasons that make her more vulnerable to reduced blood sugar control. First, hormonal changes that cause insulin resistance. Psychological changes put her at a higher disposition to take risks and seek immediate rewards behavior. This puts her at a greater vulnerability in social contexts where youth are more likely to be influenced by their peers. And finally, the transition of care is also a critical period where she has to transition from children to adult care and learn to navigate a new healthcare system, in addition to navigating family dynamics as she takes over more responsibility for her diabetes management from her caregivers. And so all of this decreases adherence to diabetes self-management in youth and exacerbates poor glucose control. And uncontrolled diabetes has serious implications. It's associated with premature death. It's the leading cause of blindness. It contributes to 30% of all strokes, 40% of heart attacks, 50% of kidney failures leading to dialysis, and 70% of non-traumatic leg and foot amputations. So to summarize, the research problem that my study aims to address is that adolescents and emerging adults experience a decreased adherence to diabetes management strategies, which is inherent to their age group, but is exacerbated by the increased difficulty in receiving diabetes self-management education and support. And I propose that online education platforms that target youth aged 14 to 24 years old specific needs based on behavior change techniques can help increase youth self-management behaviors, thereby improving their glycemic control. There needs to be a bridge between the online availability of information and its credibility and reliability. And my research aims to develop and test an online education platform where youth can receive trusted answers to their questions easily and be better equipped to manage their diabetes. In order to not duplicate efforts into developing a new platform, we want to adapt an existing platform developed by our research team of healthcare professionals and patient partners called Support, which was developed by adults living with type 1 diabetes, and we want to tailor it to meet youth-specific needs. And to do that, we previously conducted individual interviews with youth, such as Casey, to determine barriers and enablers to diabetes self-management and establish how can an online platform reduce these obstacles and enhance these enablers through features and content. And we want to embed different behavioral change techniques to encourage behavior change and adherence to diabetes self-management. So from Support, we build a prototype, which we call Support T. And this prototype is a mobile-first design. To increase accessibility to the platform, it's adapted to a smartphone format. It includes categorized education modules, a discussion forum to promote peer support, features such as quizzes, tracking progress, videos, calculators, and a news blog. So features that increase accessibility to content that is reliable, practical, and novel, that increase the sense of support and adherence to the platform were all considered in the co-design of this prototype. In terms of the timeline of the study, so we already conducted the interviews to develop the prototype. We're now in the platform consolidation and validation phases. And for that, I presented the prototype to participants in focus group interviews to validate that the prototype meets their needs. And upon finalizing the development of the platform, I want to test it out in a pilot clinical trial to validate if it does indeed improve diabetes self-management behaviors and glycemic control in youth. So the first fold of the study is the focus groups. I want to keep youth involved throughout the co-design process. And considering the collaboration between youth and healthcare professionals, I wanted to get both their input, but independently, to not influence any party. So we invited youth such as Alex and healthcare professionals in small groups to discuss what they liked about the prototype and their needs in online education. And because there is a risk of bias from the researcher influencing the subject's responses, the same interviewer was present for all interviews and was asked to follow an interview guide. And we used their feedback to make connections, to draw inferences on features and content that would increase their engagement and use of the platform. After this step, Support T was finalized and ready to be tested in a clinical trial. And the second and final fold of the research is the randomized controlled pilot trial over a 6-month duration. We recruited enough people to be able to detect a difference in their diabetes self-management behaviors. Half of the participants will have access to the platform for 6 months. They are the intervention group, and the other half will not have access to the platform, and they're the control group. So that we can compare between the groups and evaluate if our intervention, which is the use of the platform, helped them improve their diabetes self-management scores and their blood sugar levels or glycemic control. So participants in both the intervention and the control group will take the SMOD-A questionnaire at the beginning, which will measure their diabetes self-management score. We will measure their HbA1c, which is an indicator of blood sugar control, as well as time in range, which is the time that their blood glucose levels were controlled in and in a good range. We will give them then access to the platform, and during the first 3 months, we will be sending them regular reminders to log on the platform. After 3 months, we will again invite both groups to take the test. We will again take their HbA1c and percent time in range, and it will also analyze platform analytics. So how many minutes were spent on the platform and the number of logins. After this, we have another 3 months of follow-up where participants will be again given access to the platform, but this time without the reminders. And at completion of the study at 6 months, we will again do the same thing and collect the same information. And with the data that we have collected, we will perform statistical tests to analyze the data and answer our questions. Are there any differences within the same group, so in the intervention and in the control group? Was there a difference in their scores across time? Are there any differences between the control and the intervention groups to answer if the use of the platform had an impact on self-management behavior and glycemic control? And were there any differences across genders? To our knowledge, this will be the first platform to be conceived specifically for youth living with type 1 diabetes and using their input along with healthcare professionals throughout the co-design of the platform. There is an in-depth needs assessment phase before conception and testing of the platform. The platform is also empowering for youth and creates a safe environment for them to share their perspectives by limiting power dynamics. And for testing of the platform in the trial, we consider percent time in range in addition to HbA1c. So that's an additional marker for glycemic control and adds the objective measurement of the effectiveness of the platform, as well as accounting for potential gender differences. And so we hope that this platform will help youth, such as Alex, answer her questions, one question at a time. And not just Alex, but also the other 33,000 youth that are diagnosed with type 1 diabetes and that have to answer all these questions on top of dealing with the different aspects of their daily lives. So until we can find a cure for diabetes, Support T platform is the answer we hope will help simplify type 1 diabetes for adolescents and young adults. Thank you for listening.